Good morning.
So there was a little flood down the hall from the rain last night, and so it's matriculated, so just be careful, watch the wet floor. And apparently the chillers were down on the AC, and so it's back on. It'll get cool in here eventually. Maybe not before the end of your class, though. So this is lifespan alterations and growth and development. If you did not grab one of these when you signed in, please come get one. It's just a little ticket to exit. It's for me. It's not the same thing that you get from the course level at the end. It's just how was my lecture? How did things go? Is there anything that was kind of confusing to you? Because that'll kind of help me down the line. Okay, so we had internet. Let's see. Has anybody seen Miss Cosgrove before?
Yes.
Yes.
Listen, try to stay with us for the class. This is money. You don't want to waste your money. Speaking of money, the economic structure that was set up and put in place in the United States after the Industrial Revolution became a kind of, what's the word? Miss Cosgrove. Miss Cosgrove. Wow. Wow, nice. Man, did you go to sleep at all? We in here watching you sleep. I see you laughing, but I don't even think you know what the hell I'm talking about at this point. All right, hang in there, Miss Cosgrove. We got a lot to do. Now, once the funding structures were allocated to different proximities within the economic structure itself, that's when the U.S. government started to allocate different funding programs to.
So at 2:45 p.m.
Anyway, so try not to be Miss Cosgrove. Just stick with us. So we're going to talk about cleft lip, cleft palate, spina bifida, failure to thrive, Down syndrome, and fetal alcohol syndrome. And all of those are alterations that can happen in development. So if we think back to the beginning, kind of going back to patho and biology, a lot of that sensitive period of time is when that embryo is first developing. And a lot of times that happens before mom even realizes she's pregnant. So alterations can in development can occur at any point during pregnancy, but these are some particularly sensitive periods. One of those things that we know that can help prevent some of these defects would be folic acid. So folic acid, the importance of it is that inadequate intake can be associated with neural tube defects. So your neural tube, does everybody remember what the neural tube is? Ish, yeah. So you have the neural plate when the embryo is forming, and then those cells kind of fold in on themselves and forms the neural tube. And so from that neural tube comes the spinal cord and brain. Alterations in that development where we have openings can occur, for a bunch of different reasons. But research has shown that folic acid can prevent up to 50 to 70% of those. Because folic acid is necessary for DNA and RNA replication as well as red blood cell synthesis. So when we think about what a developing fetus is going through, they have lots and lots of growing and replicating. Folic acid is a B vitamin. It's actually a synthetic version of folate, which is that what we get from nature and foods. It's recommended that anyone of childbearing age take 400 micrograms of folic acid every day, and so that would be anywhere from about age 15 to 45 is considered childbearing age. The reason that's so important that we think about everyone of childbearing age is that half of the pregnancies in the United States are unplanned. So a lot of times a mom can be pregnant before she even, development's going on before mom even realizes she's pregnant. And so starting folic acid at the time she realizes she's pregnant may be a little bit too late. So we always want to encourage anyone that's of childbearing age to always take that. And then moms at risk will have a higher dose ordered. Moms that have had an infant with neural tube defects before, certain like gastric bypass surgeries, that kind of stuff. But 400 micrograms is a good number to remember. So let's look at a little case scenario. Y'all don't have this in your slides, so don't freak out. You're called to the delivery room for baby Mia, who was born via NSBD. What's that?
Spontaneous vaginal delivery.
Yes. So she had a normal spontaneous vaginal delivery at 39 weeks and 1 day to a primi gravida, which means what? First baby, first time mom. Sarah and her husband Michael. Sarah's pregnancy has been complicated by limited prenatal care. She has a history of epilepsy, and she was on valproic acid during her first trimester. Sarah smokes half a pack of cigarettes a day. Mia's weight is 7 pounds and 1 ounce, and she's got 19.5 inches long. And upon your initial assessment, you notice an obvious opening from Mia's lip to her nose that continues through to the roof of her mouth. So, first impressions, what do we think might be going on with Mia? Cleft lip, cleft palate, right? We have an obvious opening. What are some possible risk factors that we think may be going on just from this history? Yeah, so she's valproic acid, so medications that she took during her first trimester, which we know is a sensitive time, formative period, right? She's a smoker, so another risk factor that goes along with that. And then what about the prenatal care? It's limited, right? So we don't know how many times she saw the physician. We don't know if she had any ultrasounds. We have no idea, what has gone on during her pregnancy. She may not have received any education about folic acid, right? We don't know what her long story is. So let's look at cleft lip and cleft palate. That occurs basically when those maxillary processes fail to fuse. And if we look at this little blue dot that I've made, this is where the incisive foramen is. And so if you think about cleft lip and cleft palate in a normative development, this is going to close like a zipper as these fuse. So this is going to be one zipper going down, this will be one zipper going up towards the left, and one zipper going up towards the right. And so it just zips all the way down. So if the zipper doesn't zip all the way, like in this picture, we have a cleft palate, right? If it doesn't zip going up both of these sides, we have a cleft lip, right? Up one side, this is two different zippers. So we have a cleft lip and cleft palate, but it's unilateral. And then here we have a bilateral cleft lip, cleft palate. Make sense? Mm-hmm. Okay. It's possible to have different types because those zippers close at different points in development, right? So the lips close around 6 to 7 weeks. The hard palate's around 8 to 9 weeks. And then the uvula and velum at the back of the mouth is around 12 weeks. So it's possible that one zipper doesn't close at one point in development, but another one does, or vice versa. So you don't have to memorize those dates, just know that, you can have more than one type. It's the most common craniofacial birth defect. And some contributing factors can be diabetes before pregnancy, smoking before pregnancy, maternal use of alcohol, and then medications like anticonvulsants. And then studies, of course, suggest that folic acid during pregnancy can reduce that incident of cleft palate and cleft lip.
Can it be genetic?
Well, I think that's mostly, there's a lot of different factors. So if, I don't know that's necessarily going to be something that's like passed on, like DNA-wise. There's some things that can be, but I don't believe cleft lip palate is. But I can double check and let you know for sure. Yes?
Is it always, it doesn't just happen, it's always outwardly caused?
There's a bunch of different factors. So folic acid, right, that's the main one because that's kind of what's needed in replication and synthesis for that DNA. But those are, other factors like, maternal history of diabetes, smoking, those are, other things that can affect it as well. Medications, yes.
Would this be a sign of other, internal deformities?
Not necessarily.
It could be just by itself.
Yeah. So in the United States, about 1 in 1,600 are born with a cleft lip and palate, and then 1 in 17 have just a cleft palate, and then 1 in 2,800 have a cleft lip and cleft palate. Again, that's not something you need to know, just for knowledge. So this little area at the top is that maxillary. Let me go back. So this premaxilla right here if you look at this slide, you see where these zippers are. We have teeth buds in this area, and so normally when all of this fuses, the premaxilla is fused along with it. If this is open, the premaxilla has nothing to attach to, and so we have tooth buds that are in there, so they can be affected as well. So if we look at these pictures, this little area, like right here, would be a premaxilla, right? Cleft lip. The cleft lip is not painful. The palate's not painful. They just didn't fuse together. So it's not like a cut that is, hurting the infant at all. So diagnosis, prenatal ultrasound can be made as early as 13, 14 weeks gestation. That's because that's after all of those periods of development finish. At birth, diagnosis, of course, is made with a physical exam with inspection and palpation. And so part of our newborn exam, when you go through 223 and you go through that clinical, part of our newborn exam is we're, checking, we're putting a gloved finger into baby's mouth and we're feeling along that palate, along the top, at the same time that we're eliciting that sucking reflex. So as far as treatment, it's multidisciplinary. We have a bunch of different specialties of physicians, craniofacial involvement, dentist, of course, because that premaxilla right there has tooth buds in it. Orthodontic team, speech therapy, that's an important one because a lot of our speech sounds are made by opening and closing of the muscles in our mouth. And so if this is an opening right here, that baby doesn't have the ability to make that sound. So a lot of times they'll kind of, make an alternative thing. The muscles kind of, crisscross across the top of our palate. And so in these babies, they're either separated completely, where they don't work, or they're not in the right place where they're supposed to be, so they don't work as well. Make sense? So speech therapy throughout childhood kind of helps them with norms of speech development. And then, of course, social services for parent support and that kind of thing. So baby Mia continued. You're preparing to discharge Mia home with her parents. Her discharge weight is 6 pounds and 14 ounces. So she was 7'1" at delivery. Are we okay with 6'14"? Are we worried about it? Right, so we expect her to lose, up to 10%. We want her to regain that within 2 weeks. But, so we're okay with a 6'14" discharge weight, right? But what is our big concern with Mia? If she has a cleft lip palate, what do we have concerns for? Feeding and nutrition, right? So keeping an eye on her weight is going to be important moving forward. And Mia's mom reveals to you that she's very anxious about taking Mia home, and she asks when everything's going to be fixed. So what information do we want to give Mia's mom? What kind of resources do we want to have set up for her? Yeah. So first one she needs to see after discharge is who? Pediatrician, right? So new baby being discharged home, AAP wants them to be seen by 3 to 5 days after birth. They can recheck a weight at that time. And then setting mom up with different social services as far as, alternative feeders, case management, getting those specialist appointments in. So,
Something that they do after they don't do this in the hospital while the baby's in the hospital.
no, so this is a go home from the hospital and then you're going to get treated as follow-up. So, first thing we want to do, since Mia has a cleft lip and cleft palate, they're going to repair the lip first. So that's usually done between 3 and 5 months, depends on the preference of the surgeon. They may need multiple operations, but again, remember, it's not painful to Mia. It's just an alteration in that development. So the surgery is then going to focus on repairing that, and then an early closure is really going to promote sucking and speech muscle development. The cleft palate, the repair is going to vary on the physician and the size and the severity of the cleft, but it's typically closed by 12 months because we want to protect those tooth buds as far as formations, and also allows the child to develop a more normative speech pattern. And then these are going to be patients that need ongoing orthodontic care ongoing surgical care. We want to make sure that they establish early visits and see them often, because these children may have multiple surgeries over the course of a time. Of course, increased severity, we're going to pull in things like dental and orthodontics. They can make devices that help pull the palate together if needed. So we would tell me as mom, we're going to hook you up with a pediatrician, we're going to make sure you have case management, services to help you, and then we're going to set you up with your, get you started with your craniofacial team, right? What else can we tell me as mom? She said I'm anxious. Right? What do you think she's anxious about?
From feeding and
Feeding, right? So what's our biggest risk with feeding?
Aspiration.
Right, so here's a new mom, first baby, right? We don't know what was going on with her. We know she had some limited prenatal care, so we're not sure what's going on outside of the hospital. And she said that she's anxious. We're worried about feeding, so we need to give her some really, really good education regarding that as well. So pre-op, we have a big risk for aspiration and also nutritional deficits, less than the body requirements. So pre-op, we have special feeding devices, and we'll look at some pictures of some of those. They have bottles with longer nipples. They have squeezing feeders, bottles with larger holes in the nipples. So the feeding method that we teach these parents is the ESSR method. So the E stands for enlarge the nipple hole. The S is to stimulate the suck. The next S is to swallow, and then the R is for rest. So what ends up happening with these infants is that to suck and pull milk, right, you have to create a vacuum. And so normally when a baby latches onto the breast or the bottle, they kind of make a seal with their mouth and they pull, and that suction pulls milk out, and then they swallow it. Well, in this case, they have a hole, right? So there's a hole in the roof of their mouth and or their lip, and so they can't create that suction. So instead, we help them out a little bit. So we would tell mom, you're going to put that nipple against whatever spot of the hard palate there is. So we wouldn't want to put it in the middle because there's a hole there. So we would want to put it against the hard palate. And then we teach moms, we're going to hold baby upright, right? We don't want it going down this way because we don't want things going up. So we're going to hold baby upright to help gravity take effect. And then we teach mom to kind of coordinate the squeezing of the bottle with baby's sucks. So when we do that, baby has to exert less effort. So it takes energy to get milk, and we don't want these babies to exert more energy than what they're taking in. So we would always teach the parents to do small, frequent feeds, and limit those feeds to no more than 30 minutes. Because after 30 minutes, you're just spinning your wheels. The baby's burning more than they're drinking, right? And then after feeding, we always want to make sure that we're cleaning the baby's mouth with a clean cloth and then keeping them upright for 20 to 30 minutes. And we also want to educate mom that they're going to typically be swallowing a lot of air, so we want to burp them very, very frequently, sometimes even as often as like 5 minutes or so, which would not be, as typical with an infant that doesn't have cleft palate. Post-op, of course, we're worried about incision healing, respiratory, of course. We don't want to have any infections, so we want to make sure we're addressing that. Tissue integrity, addressing pain, of course, because we don't want them crying any more than we need to. And then nutrition is still a concern, and then we're going to monitor their vitals and their eye and nose. It is okay for a toddler to drink from a cup post-op, but typically, like the babies, it's going to be syringe feeding or a special feeder with those aspiration precautions, and then making sure we're cleaning those suture lines. And then the other thing with post-op is we want to make sure that we're avoiding prone positioning, right? We don't want the babies rubbing this fresh incision on the blanket, and then we want to immobilize the elbows. So elbow immobilizers for 2 weeks or as long as directed, because what do babies do with their hands? Go in their mouth, right? They suck for comfort. If this is itching or painful or bothering them, they're going to put their hands towards their mouth. So the elbow immobilizers basically prevent them from doing that. Let me see. I have I'm gonna show you a picture. If mom had an issue with resources, we could always tell her that she could pin the arms to the side of the shirt so that the baby can't pull their arms up. But if we could get her set up with those different social services, then an elbow immobilizer might work a little bit better. So we'll see if that pulls up. I'll find a picture for y'all. Okay. So, like I mentioned, the muscles of the palate are involved, and some of those muscles help open the eustachian tubes, and so that allows fluid to drain. Well, if those muscles are involved, then the eustachian tubes can't open properly, and so fluid can build up, so we have a higher risk of ear infections with those babies, which can also lead to hearing problems. So we want to make sure that we're doing real close assessments of that. And then they also have issues for developmental delays, of course, if some of those things are impaired. Parent anxiety, which of course we saw with Mia's mom, over care and feeding. And then there could be a potential delayed parent-infant bonding, thinking about, what mom is going through, can be unanticipated medical events, the stress of caring for their baby, the additional physician's appointments, maybe their baby doesn't, look physically like they were thinking. So we want to make sure that we're doing everything that we can to promote bonding between mom and baby, or caregiver and baby, and give that emotional support. So these are some examples of some of those bottles that we were talking about. There is, if you go on YouTube, you can look for cleft lip and palate bottles. There's a link. I'll try and find it and post it. We're not going to watch it for time's sake. But there's a therapist that goes through the different types of bottles and demonstrates them. But again, going back to that concept of that vacuum sucking and pulling, the Mead Johnson bottle, what this one is, it's just a very soft bottle so that when baby nurses, mom can squeeze and allow that milk to go in so that the baby's, God bless you, that baby's suck doesn't have to work quite as hard. Nook nipples, pigeon nipples, the Haberman feeder, all of those we fill the valve, fill the nipple up with milk, and then coordinate squeezing as well. Let me see if there's anything else I want to tell you about this. Always feed in upright position. Toddlers can drink through a cup. Burp frequently. Sit upright for 20 to 30 minutes to prevent aspiration. Limit feedings to 30 minutes. Small, frequent feeds. And then obviously we're going to pay attention to any signs of distress, right? If baby's having difficulty breathing during feedings, we want to watch that. Okay, so which statement by Mia's mother suggests that she has not fully understood the discharge instructions? I'll feed Mia small amounts of breast milk often. I will not let Mia feed for longer than 30 minutes. I will feed Mia laying down to help the milk drip down her throat. Or I will stop and burp Mia every 5 minutes. 3, right? We want her being upright. Looking at the amounts of breast milk, can these moms breastfeed? Right? So it's kind of a mixed answer, right? Are they going to be able to nutritively nurse at the breast? No, they're not. Do we still want mom to produce breast milk? Absolutely. So we want to encourage mom, and that can go along with our case management, hooking her up with a pump, lactation consultant. Depending on what the the situation is, we can always have babies nurse at the breast for comfort. Just being close with mom, but from a nutritive point, they're going to be getting it for a specialized feeder. If the baby just has a cleft lip, we can create that suction by holding that lip closed. So if the palate's intact, we can create that suction by just holding those lips closed, and so that may be an alternative too. But again, that would go in with bringing in those ancillary services speech, PT, OT, all of them to help mom with feeding. Okay, so I know y'all were introduced to Dr. McGuire last semester and that whole metacognition and thinking about your thinking. So I took a course of hers over the summer. Fantastic. If you don't have the book, she wrote a book called Teach Yourself How to Learn. Amazing book. But anyway, so this is part of kind of borrowed from her thing. So I want you to take a minute, look back over what we just talked about, jot yourself any notes down, like, hey, I need to go back and review this. This was a little unclear to me, so that when you sit down later to study, you're not going to remember, like on slide 12, I had a question, right? So do it right now, and then we'll move on. All right, so we're going to move on to spina bifida. So spina bifida is another one of those neural tube defects that folic acid can help prevent. And it's basically a malformation of the spinal cord and spinal canal. So when that neural plate is folding in on itself and making the neural tube, in spina bifida, what happens is the bottom of that remains open. Now, if you had an opening at the opposite end, you would have something like anencephaly where the brain isn't developing. But at the bottom, at the base of the spinal cord, it's going to be spina bifida. And so spina bifida is basically that defect where there's a failure of fusion. And then we have the sac-like protrusion that can contain fluid. What kind of fluid?
Spinal fluid.
CSF, right? Spinal fluid. And can contain a portion of the spinal cord and nerves. So this defect occurs within the first 28 days of pregnancy. Most people don't even know they're pregnant by that time. Hence, going back to why folic acid is so important. The malformation can occur anywhere along the vertebral column, but the most common areas would be lumbar sacral. So there's a breakdown in your PEDS book that'll go through this level of involvement. You don't need to memorize that. I mean, it's good for reviewing and knowledge, but just know the higher up the lesion, the more involvement we're going to have, right? Like more bowel, more bladder, nerves that are going to be affected. The cause is unknown, so there's some environmental factors indicated. Of course, chemicals, alcohol, medications like valproic acid, genetic factors can play into this a little bit, and then some maternal health conditions like gestational diabetes and maternal obesity. In the United States, about 90% of infants with spina bifida survive to adulthood, and about 80% have normal intelligence. So when we're looking at an infant with spina bifida, of course, we're going to notice this sac-like projection, right? And then, like I said, the clinical manifestations are going to depend on the site of the lesion itself. So there's a couple different types of spina bifida. The three that we're going to talk about would be occulta, a meningoceal, and a myomeningoceal. The spina bifida occulta is one that the closure, the opening is really small, but typically the skin is still going to be closed. You're not going to see an opening in the skin. But when you're doing your newborn assessments and we're looking at the spinal column and we're saying the spine is straight, we're looking at the base of the spine for that little tuft of hair or a dimple. That can be a clue in that maybe there's some kind of occulta going on. Usually, there is not going to be any kind of spinal cord or nerve involvement, so some people may have this and go through life and never even know it. A meningoceal is where that sac is there, but there's only fluid in it. And so there's really not going to be, there could be some nerve damage, but it's not going to be as much or as significant. And then the myelomeningocele, of course, is the most severe. This sac is going to have spinal cord and nerves involved, and so we're going to have much more issues related to that. There's also a type that has like a fatty tumor and all that, but we're not going to get that deep into it. So diagnosis, ultrasound, and then when we do lab work on mom during pregnancy, we can see an elevated maternal alpha fetoprotein level. And then, again, the prognosis is going to depend on the type of the defect, the level of the lesion, and any complications that go along with that. So some associated complications. Hydrocephalus is the most common that's associated with myelomeningocele. About 90 to 95% of individuals are going to have hydrocephalus. What is hydrocephalus? So buildup of that fluid, right? So that could result in decreased mental function or visual deterioration if it's not treated. Seizures, of mobility problems, of course, are going to have a level of involvement of nerves. Intellectual disabilities can happen, like learning problems, ADHD, perceptual motor skills, problems with memory, problems with numeric reasoning. Some visual impairments, spinal curvatures like scoliosis or kyphosis. Of course, we're going to see musculoskeletal issues and some hip issues as well. Variations in walking. Some people may be wheelchair bound. Some people may use assistive devices. Skin sores. Why do we think skin sores?
Mobility issues.
Mobility issues, and also those nerves are involved, right? So we have some sensory impairment, so they may not realize that they have some breakdown going on in their skin. Precocious puberty, sexual dysfunction, and then urinary incontinence or retention, and then bowel incontinence or constipation. And again, because those nerves are involved. With urinary incontinence, we worry about renal damage resulting, so we keep a close eye on that. Surgery, you could actually do surgery in utero around, as early as 26 weeks or so. So it's going to reduce the need for a shunt, right, because it's being repaired in utero. But what's going to be my big risk if I'm doing surgery in utero? You're on the right track.
Yeah, I can't get the word out.
Popping the water bag, which is called the amniotic sac or amniotic membrane. So if I break the water bag, then what am I at risk for? Infection, premature labor, premature birth, right? So if they have surgery in utero, it could repair it, but we also run a risk for preterm birth. So they have to kind of weigh out benefit risk. So if surgery is not performed, then the baby's born, they look at him after delivery, and then they do imaging like MRIs and ultrasound or CT scans. And then subsequent testing is going to evaluate bowel and bladder function, and then neuromotor function, and then cognitive function as well. Typically, we do surgery within the first 24 to 48 hours after birth because we want to reduce the risk of infection, right? They have this sac that's protruding on the outside of their back, so what infection are we worried about the most? We have a sac that has spinal cord involvement.
Osteomyelitis.
No, it's not really bones. Spinal, so that would be called meningitis, yeah. So our team of healthcare providers is going to be multidisciplinary again, doctors, nurses, different therapies, so PT, OT. We're going to have neurosurgery involved, of course, orthopedics, GI, urology, and then these patients typically have a lot of surgeries. And again, prognosis is going to vary based on the severity. So pre-op, of course, we're going to do all those images. We're worried about meningitis, so we want to make sure that we're doing really frequent assessments and looking for signs of infection. These babies are going to be put in a prone position. Do we typically put babies prone? No, so that is something that is kind of unique to this. We don't want them laying on that sack and putting pressure on it. So when we put them in that prone position, you see this baby has the hips that are kind of flexed, and that's really just to kind of decrease that tension on that sack. We can put them underneath a warmer to keep them dry, but we don't want this sack to dry out. So we keep wet dressings on it, sterile saline soaked dressings, and we change those every couple hours. And that's something else that's a little unusual. You know, typically when we're doing dressings, we don't want wet stuff against the skin, right? So wet dressings to prevent the sac from drying out. We're going to watch for skin integrity, monitoring for signs of infection. Of course, we want to protect from trauma, and then we want to keep the area clear from any contents of the diaper, so really good diaper care. We're going to monitor the sac for leakage, right? We're going to do head circumferences daily. Because we know that 90 to 95% of these babies are going to have hydrocephalus as well. So the fluid can get in and it can't get out. So how would I know if this baby's got signs of hydrocephalus? Fontanelles are going to be bulging, right? And then what about head circumference? It's going to increase, right? Neurological assessments in nursery, looking for sensory motory function. A lot of times they have more pronounced sensory involvement on the backs of the legs. And then we give extra attention to the anal reflex. Is there one there? Is it present? Because the lack of nerve sensation is going to put these children at a higher risk for incontinence and constipation. And then we assess their urinary output to determine if there's any kind of neurogenic bladder going on. And then we want to encourage the family members to interact, of course. So kind of same thing, you know, your baby was born with a medical condition. They, you know, usually it's discovered in utero. If we have good prenatal care, it's discovered in utero. And so the parents may have had some time to kind of acclimate to the idea, but that doesn't always prepare them for, you know, what's going to happen after their baby's born. And so now I have my baby, I can't, you know, swaddle and cuddle and hold my baby, and so that can impair a little bit of interaction with them. So we want to encourage them to be involved. And we can feed these babies in a prone position. We just do small amounts of you know, feedings frequently. Post-op, of course, we're looking at vital signs, that head circumference. A lot of times they place a shunt, and so if a shunt was placed, then we're going to have post-op care for that as well. So that shunt, of course, remember, is that when we put that little tube in the head, it goes down and drains into the abdomen. That way, that buildup of fluid can go down to the abdomen and be reabsorbed by the body. We're looking at that surgical site, of course, monitoring for complications of that, signs of infection. We want to manage their pain for sure. We don't want these, you know, babies to be crying and fidgeting, and we don't want them to be in pain. Monitoring their urine and bowel output, and then we're going to start range of motion exercises. Right, cleaning the incision per, you know, the facility or physician's order, and then again encouraging the parents to be involved and offer emotional support to them. So discharge planning is going to be important for them as far as any special equipment that they're going to need, ancillary services. Again, these are long-term patients. It's not a one-and-done kind of thing. So these children are going to be in the healthcare system for a long time. So let's see if we can get Decatur to pull up.
We knew that she had a fairly large myelomeningocele, or what most people would understand as spina bifida.
The spinal cord is open. If your spinal cord is open, that means your cerebral spinal fluid, it's all in communication with the outside world. So the biggest risk at that point is they can get an infection. If they get an infection, that's meningitis, and that's very serious in the baby. But what we aim to do is close the skin, create a barrier between the outside world and the spinal fluid, and therefore prevent infection.
Reach in with this forceps and grab the white band.
Over time, it became
is to place a ventricular peritoneal shunt, which is the treatment for hydrocephalus. People who have hydrocephalus, they don't absorb the fluid, although they continue to make it.
Yeah, I think a couple more of those and some Dermabond.
So you need to move it somewhere else. So the shunt is basically plumbing to move the fluid from the brain down to the abdomen, where it's ultimately reabsorbed into the bloodstream, just like it would be in the normal situation in the head.
Yeah, looks good. And then once she finally got to the point where she had stabilized, was eating well, we were actually able to get her home at that point.
That is our beautiful baby. We're enjoying her home right now.
I think the one thing that gives these kids the best opportunity for the best outcome is that there's a coordinated kind of care center that our neurosurgeons and other specialists manage for spina bifida clinic, and that they are actually able to help these kids end up with their best outcome.
So it kind of puts a little visual to it, huh? So thinking about nursing interventions, of course, if we can prevent it from happening, that's great. So how do we prevent as much as possible? What do we tell the parents? Folic acid, right? So if we can educate women of childbearing age, so that teenager to all the way to 45, about taking that daily folic acid, we may be able to prevent this from even occurring. Allergies, kind of an interesting thing. A lot of times people with spina bifida develop an allergy to latex. They don't really know why. A lot of times they think it's repeated exposures in the hospital setting over and over and over again. But we would want to educate the parents about signs and symptoms of latex allergy, as well as foods that go along with it. So things like banana and kiwi, what else there, papaya. Make sure that parent is aware of those kind of things. Avocados is another one. We want to promote safety. So assistive devices, skin breakdown, making sure that, however as the child ages, whatever they're going to use for mobility, whether it's, assistive walking devices or wheelchair, that we have safety in the home and in the environment for that. A diet that's appropriate calories. We don't want them to be obese, but we also want an appropriate diet that's going to decrease the chance of constipation or fecal impaction. So lots of good fluid intake. We don't want them to restrict fluids, and then definitely want a diet high in fiber. And they may need like suppositories or something to promote bowel evacuation. As they age, educating the child about performing in and out catheters, and making sure that we give them educations about the signs and symptoms of infections. So, fever, dysuria, new onset incontinence, that kind of stuff. And then also we want to encourage socialization, and then assessing mental health of the child as they age. So we want to promote them to be interactive with their peers, and make any modifications as needed to have normative interactions. These are some therapeutic managements, so it doesn't have to be done, but something that can help as the child ages. So mitrofanoff is basically where they take, instead of urine coming in the bladder, they create like a little channel that allows the child to catheterize themselves through their abdomen. So they may put a stoma kind of by their belly button. It could be near it, and so they insert that catheter and catheterize themselves. So that can help with decreasing the need for diapers. Allows the child a little bit more independence in the school setting. And then the MACE procedure is just basically where we have allows an infusion of an enema to promote evacuation of the contents in the colon. And, kind of decreases fecal soiling. And the goal as far as bladder management, whether it's this or anything else, anything related to neurogenic bladders, we want to prevent any kind of kidney damage. And we want to maintain that bladder function. So, what findings would the nurse expect to assess when caring for an infant diagnosed with hydrocephalus? Would we see a bulging anterior fontanelle? Yes. Difficult to soothe. Yeah, if we have a buildup of fluid, right, so we can, difficult to console, high-pitched cry, right? Eyes rotated downwards, that's sun-setting sign, so those are all signs of high pressure. High-pitched cry, yes. Head circumference within normal limits? No. Probably not. We would expect to see an increase. All right, so same thing, do your 1 minute takeaway.
Question.
Yes.
Do they have any difficulty, like feeling the bladder enlargement, or the?
So if they have nerve involvement, they may not feel it at all.
So do they have to be on like a schedule, like voiding every 4 to 6 hours?
Yeah, so we would tell them you want to catheterize yourself like every 3 to 4 hours, something like that. Yeah. Yes.
Do they keep the shunt forever?
They usually replace it as they age, make the tube longer and
But
larger.
it is something that stays permanently.
Usually, definitely through childhood. All right, so let's talk about failure to thrive. So failure to thrive is defined as a BMI weight below the 5th percentile on the growth chart. So weight is consistently beneath that, that 3 to 5% line. Or you can have a progressive decline. So if we have like a decrease in weight over 2 percentiles where the baby was tracking normally and now all of a sudden starts dropping down percentile-wise, in a short period of time, that could also meet the definition of failure to thrive. It happens in about 5 to 10% of kids that are seen in primary care settings. When I was in clinic, I worked as a nurse practitioner in a peds clinic, and I actually had 2 patients that had failure to thrive. Some risk factors that go along with that. Of course, infants deprived of mothering. And so if an infant has, fails to establish this kind of long-term loving relationship, that can affect their growth and development. Parents that have depression or mental health issues. What's a common mental health issue that we see in new parents? Postpartum depression, absolutely. Infants living in poverty. Why poverty? Right, so food insecurity. So either, baby's not getting fed enough because there's not enough in the house, or maybe baby's, the milk is being diluted for some reason. Infants described as irritable. They're at risk for failure to thrive. And that may be simply because they're hungry, because the parents are either ignoring the signs of hunger or they're unknowingly not offering food. They're not recognizing it, right? And then some health conditions. So failure to thrive can be a couple different things. So we can have organic, meaning there's something physical going on in the body, a medical condition that's caused it. Something like congenital heart defects, CNS diseases, chronic illness, endocrine or metabolic disorders like diabetes. And then non-organic is going to be kind of most of those cases, about 80% of them, and that is multifactorial in origin. So infants with inorganic failure to thrive can show a delayed development without any physical cause. So basically they're not gaining weight, or that percentile is decreasing, but there's nothing really physical going on that we can see. And a lot of times that goes back again to poverty, poor bonding, maternal depression. And then you can have a mixed, which is a combination of both. So the baby has something physical going on, and then that impairs with the caregiver's sense of adequacy and ability to provide care. And so then you kind of have one that feeds into the other, right? Could be some bonding issues related to the medical condition going on. So here's Mia again. Mia's mother brings her in for her 4-month well child check. She's scheduled to have her first surgical repair next week. So that would be which one? Lip, yep. You notice that Mia's mom is not as talkative as usual. She states that Mia has been pretty fussy lately and isn't sleeping well. And today's Mia's weight is 10 pounds and 15 ounces. So before we look at her growth chart, what are some things that could potentially be going on?
Not eating, like depression.
Right. So, mom's could be having some depression. She's not as talkative as usual, right? So we want to explore it a little bit more. She says Mia's been pretty fussy. So that could be some something going on there, right? Is that related to food? Maybe. She's had some disrupted sleep. So we could look at that really easily and say, oh, this is absolutely failure to thrive. It's a bonding issue. You know, mom's depressed. But what else is Mia at risk for? What's really common in kids with cleft lip, cleft palate? That's also common in babies in general. Ear infections, right? So mom says she's been pretty fussy and she isn't sleeping well. So maybe I want to ask mom, when did that start? If Mia's been fussy for 2 days, right, then maybe she's got an ear infection going on and that's disrupted her sleep. If it's been weeks, right, so maybe mom's not talkative because she feels like a walking zombie because Mia hasn't slept the last couple nights. So we'd want to make sure that we're doing a good physical assessment, checking for fever, all that kind of stuff. But also some risk factors that we know. We know that she's got this physical impairment, right? We know that she's got a cleft lip, cleft palate. We know that mom is a little bit higher risk for postpartum depression just because of her baby's condition, first-time mom, and unexpected birth outcome. So it could be some depression too. So we need to dig a little deeper. So let's look at her growth chart. What do we notice about the growth chart?
Going down.
She's going down, right? So in the beginning, it looked like she was kind of trending around the 50th percentile. And now over the last couple of visits, she's gone way down and she's crossed down and now she's, right at below the 5th. Why is the growth chart so important in peds?
Trending.
Yeah. Why do we care what it trends?
Because if your baby
If it's not there,
they can monitor the growth.
Right. So good physical growth is an overall indicator of development. So poor growth in infancy is associated with higher childhood morbidity, mortality. And weight is our most sensitive indicator of nutritional status in children. So what are some questions? So now we have what Mia's mom told us. We have her growth chart. What are some questions we might want to ask Mia's mom now?
How is she eating?
Yeah, well, how much is she eating, right? How much is she eating? How often? How long is she eating for? So remember, we want her feeds to be less than what?
30 minutes.
Right, so maybe mom's feeding her enough, but she's feeding her over 45 minutes, and Mia's burning a lot of calories. So we have to do a really good assessment and kind of dig down. What about elimination? Yeah, how many wets and dirties is she having? Is she voiding and stooling? Sleep schedule. Like we said, is she been disrupted and fussy for 2 days, or has this been going on for weeks? Because that's going to give us a clue in too, combined with the physical assessment. And then mom's mood, right? So, hey, mom, you seem not super talkative today. What's going on? Digging a little deeper to say, is mom just saying, oh my gosh, I'm just exhausted. I haven't slept the last 2 nights. Or does mom maybe have some postpartum depression issues going on, and looking for, bonding issues with Mia. So clinical manifestations, of course, the number one thing we're going to see is that decrease below that 3rd to 5th percentile. Developmental delays, so we're not going to achieve those milestones. We could have decreased muscle mass or hypotonia. They're just not getting the volume in, right? Distension of the abdomen. The babies can be withdrawn or apathetic, and so they can avoid eye contact and physical touch. They may have a lack of preference for their own parents. Why is that? Right. If they have not bonded, if it's a bonding issue with their mom, then why am I going to look to you? You're no different than anybody else. You're not going to meet my needs. And so they may also have a lack of anticipated stranger danger. So normally, when infants kind of reach that milestone of stranger danger, when someone new walks in, they automatically look to their person, right? Is this person okay? They kind of check it out. But sometimes these infants with failure to thrive don't have that. They don't have a stranger danger. And then, of course, sleep disturbance. So diagnosis, we want to do a thorough H&P, medical, family, social history, a good diet history, and then lab testing, because we don't want to assume that it's, even though most of the cases are going to be that, kind of inorganic, there are going to be some that are related to a medical condition. And so we want to make sure that we're testing for those and doing appropriate labs. So our diagnosis is mostly going to occur through assessment. We're looking at parents during those times of feeding, and we may need to hospitalize these children to reestablish feeding and sleeping routines. And then as far as looking at not just their feeding, but how does the parent interact with the baby, right, during those feedings? Are they involved? Are they able to soothe the baby? Is the baby able to be soothed by them? And then just overall general interactions. Some associated conditions, of course, growth and development delay, a compromised immune system, poor wound healing, and then overall physical and functional decline. So undernutrition is shown to slower bone development, and of course, babies and infants and children are growing rapidly, and so it can lead to growth failure. Chronic malnutrition in the first 2 years of life can result in a limited brain size, so an acquired microcephaly, and that can lead to lifelong cognitive issues. So some learning issues going on if we're not treating it, catching it. Treatment is going to focus on treating the underlying cause of illness. So we want to make sure that these babies are getting adequate calories, that they're having any kind of replacement of vitamins and minerals. And our overall goals are to make sure that the child is achieving adequate growth and development. So we would want to follow them very, very closely and plot them on the growth curve. There's really no medications indicated unless there's an underlying physical condition, right? So if the baby has failure to thrive because they had diabetes, well, then we want to fix the diabetes, and then maybe we can fix the failure to thrive. And then our nutrition focus, we want to make sure that we're removing barriers. We never want to be in a judgmental position towards the parent, and we don't want them to feel any kind of shame. We want to encourage them to be involved in their child's care. And then increasing those calories until they get back to normative development. Make sure that the parent is educated, right? So maybe the parent didn't realize what was going on feeding-wise. Maybe they didn't, maybe in the case of Mia, say mom had been feeding her too long. We need to educate about length of feeding. So making the parent education match what's going on with the child. Some prevention and education, of course, taking that accurate history and those accurate assessments. Doing those developmental screenings to make sure that the baby is either righting themselves and getting back on track. And then, of course, observing those interactions. A lot of times, they may need some home health and continue. They may be visited a little bit more frequently to make sure that growth is continuing. All right, so Mia has been diagnosed with failure to thrive, and she's been recommended to see a lactation specialist to assist with breastfeeding. So what's an appropriate goal when planning care for this family? Do we want to increase the number of well-child checks? Increase in well-child checks isn't necessarily going to do anything. We may want to have some more frequent interactions and weight checks, but a well-child check, not necessarily. Do we want to prevent any complications associated with poor nutrition? Yes. Possibly, yeah. Do we want to improve the parent-child relationship? Yes. If it's an issue, right? So it says she's been diagnosed with failure to thrive. It didn't give a reason why. So I'd want to look at it and say possibly, and then convince the mom to use formula instead of breast milk. No, right? No, that's not going to be a good answer. Okay, so 1 minute takeaway.
So this isn't something you have to report as like abuse or anything, right?
If there's abuse and neglect causing the failure to thrive, then it would end up being reportable, right? So, like in the cases of my patients, one ended up being a reportable event, one was not. So it just depends on the situation. We're going to stop right here and take a 10-minute break because we know our minds get saturated quickly and we can't absorb anything. So 10 minutes, stretch your legs. We'll meet back at 9:10, and then we'll do our last two. So the last two we're going to talk about is intellectual disabilities, Down syndrome, and also fetal alcohol syndrome. So with intellectual disabilities, if you use the American Psychiatric Association, their definition is it's identified by problems in both intellectual and adaptive functioning. A more basic definition from CDC, which I like a little bit better, is that an intellectual disability is a term used when there are limits to a person's ability to learn at an expected level and function in daily life. Right? So I like that one a little bit better. I just think it makes a little bit more sense intuitively. So first we want to identify the disability. We can do that through good history taking and observation, and then those all-important developmental screenings in childhood. So patients with an intellectual disability, of course, are at risk for developmental delay, self-care deficit, compromised family coping. So we would want to make sure that we're offering emotional support and education to the parent as far as their diagnosis and expectations, giving them information on respite care, doing things like genetic counseling to see if there's a genetic cause for it, and then appropriate education with regards to IEPs in the school system, and then involving case management for appropriate community resources. Making sure that we're maintaining a safe environment as well, and then promoting patient independence at the level of their ability. So if we had a hospitalized child, we want to make sure that we're encouraging them to maintain their function at whatever their pre-hospitalization level of function was. So for example, if you have a child that is potty trained, we don't want to say, oh, you're in the hospital, we're just going to go ahead and put you back in diapers. We want them to continue at their level. And so same thing as far as encouraging parents to recognize those strengths and maximize those opportunities. And then as they age, thinking about vocation, are they able to work independently? What level are they able to work and function independently? Sexuality, and then as they grow, are they going to live independently, live in a group home, community homes, or are they going to live with family members? So let's talk about Down syndrome. So it was actually named after Dr. John Langdon Downs, or Down, and there's 3 types. The most common one that people think of is trisomy 21. And so that's basically where this 21st chromosome has made a 3rd copy for some reason, and every part of the body has that 3rd chromosome, and so then we see those characteristics. The next type is a translocation. So part of that chromosome, so like this one of these little arms of the chromosome, makes itself and attaches to another chromosome. That's a little bit less common. You don't necessarily need to memorize that. Just knowing that there's really no distinctive difference, but that type translocation could be passed on genetically. So the trisomy 21 just occurs by chance, and that's going to be like 95% of your population. And then the third type is called mosaicism, and that's a mixture of cells. So what ends up happening is that some of the cells have 3 copies of the 21st chromosome, and some have just the normal, regular 2 copies. And so you end up with a mosaic through the body, and so typically you're going to see milder symptoms, right, of that syndrome itself, because not all cells have that 3rd chromosome. The exact cause of Down syndrome is unknown, but advanced maternal age is the greatest risk factor. And these patients are going to have a variety of anomalies that can appear in multiple body systems, including the eyes and ears, hair, mouth, tongue, heart, brain. They have varying degrees of impairment with intellectual and social and language challenges. And their IQ can vary in range from mild impairment to severe cognitive impairment, intellectual disability, but most patients are going to be somewhere in that mild to moderate range. So this picture is actually some friends of mine that I went to school with. This is their daughter, Evie. She's precious. I do have their permission to speak about her, but that is Evie. So we'll talk a little bit more about Evie. So Down syndrome, it's about 1 in 700 births. It's a little bit more common in boys than girls. And they have a variable life expectancy. So average is about 60 years, but that can vary by as much as 10 to 20 years longer, depending on the individual and their health conditions. You don't have to memorize this chart. I know that y'all have had regular development, and y'all do need to memorize those milestones, right? But just know that you're going to see a delay, right? So typically in a child with Down syndrome, their regular achieved milestones are going to be behind that of their peers. So again, don't memorize it, but just know that you're going to see a slower average age of acquisition. When it comes to care, they actually have specified growth charts. So Down syndrome, people with Down syndrome typically have a shorter stature. Like I think the female's average height is like 4'9". Well, if you plotted that on a normal growth curve, they would be way down in percentiles. But we know that almost all individuals with Down syndrome are going to have this shorter stature, so they have their own growth charts. And then they have specific guidelines for care when they come in for routine well child. So that suggests different times of evaluations and screenings, cardiac function, growth, any other areas that could potentially be affected for early identification and treatment. And then they also have special topics for anticipatory guidance. So anytime you have a pediatric patient that comes in the well child setting, we do anticipatory guidance. So we're teaching the parent in anticipation of what's to come. Down syndrome has its own set of anticipatory guidance. So in our assessment, this is broken down in your PEDS book, but we know that we'll see microcephaly with a flat occiput. What's that? Back of the head, right? So flattened back of the head. They may have a wide, flat nasal bridge. Inner epicanthal fold, so we have that typical eye appearance. Brush field spot, so if you actually look at their eye itself, surrounding the iris, there's this little series of white dots and spots, and they call those brush field spots. Low set ears, so low in relation to what? Eyes, right? So low set ears in relation to the eyes. Small mouth and nose, protruding tongue, a short, wide neck. They can have skin modeling, hypotonia, so some poor tone. A single palmar crease. So most of us, if you look at your palms, you should have like three lines. Some individuals have just a single line going across their palm. Very common in individuals with Down syndrome, but you can also see it in the Gen Pop. So just because someone has a single palmar crease, you wouldn't say, oh, that's diagnostic of Down syndrome. You would say, there might be something else going on. Let's look a little bit closer. But you can have a single palmar crease and have no other issues at all. But it should be a clue to look a little bit deeper. They have broad, stubby feet and a large space in between the first and second toe, which is called a sandal spot. And this is actually a picture of Evie's footprint when she was at the pool one day. So her parents are big advocates in the Down syndrome community in Baton Rouge, and so they have a very public social media page, and they try to do a lot of education. And so her dad had put up this picture one day that shows this clear separation in her toes. So it looks like if you had a flip-flop on, so that's why they call it the sandal spot. Diagnosis. There's an increased diagnosis prenatally. First trimester we have testing, screening and diagnostic tests. So remember, a screening is where we kind of screen lots and lots of people, everybody, and some of those people may be positive, and then we go a little bit deeper to diagnostic testing. So first trimester, ultrasound, you may see some characteristic things, positive quad screen in the blood, and then if those were positive, a parent could be offered the opportunity to do further testing, like amniotic fluid sampling or chorionic villus sampling. And so some parents may opt to go that route and some parents may not. We just, make sure that they are aware of their options and educate from there. Postnatal diagnosis can be made with physical exam and genetic testing. Prenatal testing, some of the tests, like I mentioned, the quad screen, so that'd be like maternal alpha fetal protein, different hormone levels, estriol. And in Iceland, just interesting fact, Down syndrome has almost been eliminated from the population because of genetic screening and counseling and their abortion rates. And then prenatal testing here accounts for 40% of fetuses being aborted in women greater than 35 years of age. But in Iceland, here it's 1 in 700. In Iceland, you may only have 2 or 3 people born with Down syndrome a year. Some associated conditions. About half of the infants born with Down syndrome are going to have some kind of congenital heart defect going on. So we want to make sure we're paying attention to that. They can have congenital hypothyroidism. That's picked up on the newborn screening. So when you're in nursery on your 223 rotation, you hear them talking about doing the baby's PKU after 24 hours. PKU is just one of those tests that they're looking for on the newborn screening. So hypothyroidism is another one. Hypothyroidism is important to treat because there's relatively no symptoms very early on, but if we don't replace that thyroid hormone, then we have cognitive impairment. They can have hearing problems and vision problems, skeletal abnormalities, some GI-associated diseases like celiac disease, diabetes, duodenal atresia. They can have orthodontic issues, poor growth in childhood, but obesity as they age. They can have skin issues, dermatologic conditions, and a lot of times the male individuals with Down syndrome are infertile. And then there's a varying degree of intellectual disability. As they age, they could potentially develop dementia. And there's also an increased risk of leukemia in individuals with Down syndrome. So some of our nursing interventions, of course, we want them, just like all of our other patients, to have a great quality of life. Screening for associated conditions and managing those. So if, they ended up having diabetes, we would want to make sure we're treating it for that really well. Educating the parents on anticipatory guidance of what to expect, as well as education about their associated conditions that go along with it. Encouraging the parents to really recognize and maximize their areas of strength and identify areas that need a little bit of adaptation. Same thing in the education setting. We want them to have good IEPs. We want to promote optimal development and socialization. And then place some referrals for ancillary services as needed, along with different case management things. And then also, along with that case management, is identifying if there's a need for respite care, right? Because the caregivers are going to have an increased strain from associated conditions, and so knowing that they have that resource built in. And then as the patient ages, the educational focus, again, may shift to vocation and sexuality, and then the goals of living independently.
Respite care is just long-term care.
Respite care is kind of like relief care for the caregiver. Like it's like giving them a break. Having, services come in to, do a sitter or something like that so that they're able to get out and have a little bit of time to do whatever they need to do. So these are just a couple of examples of therapy videos, and these are EB. So this is PT.
Oh my girl.
And I think she's around 2 in this picture, climbing downstairs. So they simulate with those mats.
Oh my girl.
You can see a little bit of balance, right? And also a little bit of hypotonia.
Oh my girl.
So that's PT.
I want to cheer for her, back here. I want to be like, yeah.
And then so this is speech. So you can see
See a blue star. Now it's your turn. Very good.
So you can see tongue issues, right?
See a blue star. Now it's your turn. Very good.
And so this was right before she was 4.
Nice.
Now,
More like high five her.
Can you bring her to school?
So the caption on this one, her dad said Down syndrome and type 1 diabetes, and she has diabetes. Couldn't stop this amazing little 6-year-old from reading. TikTok, though, got involved and made it awkward, and you're going to see why.
Fun.
That's not what I wanted to do. Hold on.
Yeah. He is the blood. Yeah. We the what a bird is awesome. Yeah. We see a bus. Yeah.
She has some self-cheering on.
We have A, good, A, I have, and a nut. Yeah. And that's the last time. Okay. We have fun. Yeah.
That's Evie. As far as advocacy for Down syndrome and other disabilities, Evie's father, when she was born, she, like half of individuals with Down syndrome, had a congenital heart defect. And so they found out that in the event it was severe enough that she would need an organ transplant, they found out in Louisiana you could be denied the right to have an organ transplant because of disability. And so they were not okay with that. And so they kind of led the charge, and House Bill 143 is now known as Evie's Law. And so in Louisiana, you cannot be denied organ transplant. So it was passed in 2019, yeah. So they had 6 other states that followed suit after that with bills that were named after a child directly impacted by disabilities. So that was Evie when she was like 1 or 2, standing on the steel. She is 6 now, 6 and a half.
That's more recent.
Yeah. So this was when she was little bitty, but the reading video was more recent. So that's Down syndrome. So the last one we're going to talk about is fetal alcohol syndrome. This is, of all the exemplars we talked about today, this is the only one that is 100% preventable. So everything else we can, kind of negate risk factors a little bit. We can try and work on education and prevention, but fetal alcohol syndrome can absolutely 100% be prevented. And it's caused by exposure to alcohol during pregnancy. Formative areas of development, first trimester, of course, is a sensitive time period, but any exposure at any point in pregnancy can lead to fetal alcohol syndrome. Even though those physical birth defects can occur in the first 3 to 8 weeks. It's the leading preventable cause of intellectual disability, and the effects on the brain are permanent. There is no fixing it. So this is Natalie.
While your new double oven is taking care of dinner and dessert.
Pause for egg. Wayfarer's got just what you need.
Judged people like me. Growing up, I thought a woman who drank while she was pregnant was just about the worst kind of monster there was. Hey, Nat, we have to stay away from the camera, okay? It's just gonna look at you.
Natalie, what's it like to be you?
I'm 6. Are you ready?
I'm ready. Are you ready?
Yeah.
What do you want to tell everyone?
I want to tell dinosaurs.
All right, tell them about dinosaurs.
Because I like the long necks.
Before Natalie came into my life, I was a mess. And I was drinking on a daily basis. And she was born at 28 weeks, so about 3 months early.
What's the best thing about Natalie?
She's the best sister I've ever had.
I was planning on giving her up for adoption because I couldn't take care of myself, so I certainly couldn't be responsible for taking care of somebody else.
What's your favorite thing about dinosaurs?
The Tyrannosaurus Rex.
What does he say?
Since the day she was born, that idea was never spoken of within my family. Like, we never revisited that subject.
We feel like we're friends, not sisters. But we're sisters. And not
It was in the NICU for 3 months from when she was born, and so during the first month I went back to rehab.
If you could tell the whole world one thing, what would it be?
I'm a horse.
You're a horse?
every day I'm grateful to be alive. She saved my life. And then her sister came along, and we just became a fun little family.
La 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 la.
So that's Natalie. So fetal alcohol syndrome is like the more severe version, which is what Natalie has. But fetal alcohol spectrum disorders is kind of that, encompassing. So you can have, impairment from mild all the way to severe. So it describes that a wide range of effects of alcohol on the developing fetus. And so we can have ranges from alcohol-related birth defects to heart, kidneys, bones, hearing, all the way to alcohol-related neurodevelopmental disorders. So like an intellectual disability. To the most severe version, which is fetal alcohol syndrome. So think about the fetal liver, whatever mom's taken in, the placenta does a great job at a lot of things, but it allows alcohol to pass through it. And so mom ingests alcohol, the fetal liver really isn't able to handle it, and so baby has, same amount of alcohol as mom does.
So when they come out, they have to withdraw from that alcohol?
Depending on how close to delivery and how heavily mom was drinking. Because we don't know what amount of alcohol is safe during pregnancy. So somebody could have had one night of alcohol, at one point early on, and then later on their child displays fetal alcohol syndrome, spectrum disorder. Or they could be like in this case where they drank every single day. And so we would monitor for that, yeah. And we'll actually talk about that in just a second. So when we look at assessment, physical characteristics, thinking back to Natalie, they have a flat mid-face, and then that low nasal bridge. The philtrum is this, in an infant with fetal alcohol syndrome, or like Natalie, you saw it as well, this normal little teardrop that we have on top of our lips, that's your philtrum. Well, in individuals with fetal alcohol syndrome, it's flat. And so if you think back to Natalie, she had a flat area up here and a very thin upper lip. So it's kind of some characteristic faces. And then these babies typically are small for gestational age, and they often have restricted weight and length and head circumference. They can have some CNS irritability, so some hyperactiveness and jitteriness, and that high-pitched shrill cry. Heart defects, frequent yawning and sneezing, respiratory distress, sweating and feeding difficulties. They can have some optic nerve involvement, hypoplasia, and hearing loss. They can have kidney and skeletal abnormalities, and lots of developmental delays. And they can also have an increased need for non-nutritive sucking. So what does that mean? Yeah. Yeah, so they just have this strong desire to suck, but it's almost when you see it, it's almost like aggressive is probably not the right word, but it's just this very strong increased need for sucking.
Like a oral fixation, or?
Yeah, it's kind of a I guess a soothing mechanism. Babies suck for comfort anyway, but in these infants, it's greatly increased. So diagnosis, growth deficits, and then those characteristic facial abnormalities, and central nervous system abnormalities. So that degree of mental impairment, problems with communication, poor memory, limited attention span. Think of Natalie, kind of bouncing all over the place. But they typically have some degree of mental impairment. Some associated conditions, cognitive and motor delays, so developmental delays. They can also have failure to thrive. Poor feeding, and irritability, hearing disorders, defects in craniofacial development, and then behavior disorders. So they can be aggressive, They can have attention span, ADHD issues, delinquency. Children with FASD and fetal alcohol syndrome, particularly if they remain undiagnosed and untreated, are at high risk for adverse life outcomes. And so they can have inappropriate sexual behavior and disrupted school experiences. They can get in trouble with the law and be incarcerated and have issues with homelessness and unemployment. They may have substance abuse issues and chronic mental health problems. And they can also have premature death, most likely from impulsivity and poor judgment. So our treatment is, first off, prevention. So educating all women of childbearing age that there's no safe amount of alcohol during pregnancy. And promotion of abstinence of alcohol before conception and throughout pregnancy. And then we would want to screen to identify high-risk moms. And then when we're talking to our moms, we want to make sure that we're using open-ended questions and avoiding judgment. Because really our goal is to decrease their consumption, right, and get them help. And if we're judgmental, then we're more likely to increase shame and push them away. So we want to make sure that we're coming from an area of compassion. Many of the effects of fetal alcohol syndrome are going to last forever. But with early intervention, some of those symptoms can be lessened a little bit to help improve quality of life. Special education services, again, IEPs in the school setting to meet them at their level. Involving social services, so if if we have addiction issues, if we have whatever physically or mentally is going on with them, appropriate services and therapies to help moms with that. Respite care could be another thing, and then adaptive living skills as they get older. So as far as living and employment, meeting them as far as their level of mental impairment. So if we had a baby in the nursery that we know mom has used alcohol, we want to make sure that we're watching for those withdrawal symptoms, right? So performing our NAS scoring per protocols, monitoring their vitals and their daily weights, looking for signs of withdrawal. Typically are going to appear, within the first couple days, but could be even weeks later. We want to make sure that we're avoiding aspiration and monitoring them for seizures. Obtaining meconium for a drug screen. What is meconium? For stool, right? So it's in the baby's gut when they're born, so whatever they're exposed to in utero should theoretically be in their meconium, but once the meconium's passed, it's passed and you can't go back and collect it. So we want to get that meconium for a drug screen at birth. And then meds if they're prescribed, because our major goal is to really decrease seizures. So things like morphine, methadone, that kind of stuff are going to decrease that. And then soothing the infant as well. Of course, we want to swaddle them, offer them a pacifier, decrease our stimulation. All right, so the nurse is caring for a newborn diagnosed with fetal alcohol syndrome. Which nursing intervention should be included in the plan of care? Do we want to place the infant close to the nurse's station and separate them from their mom? No. Do we want them to be NPO? No. Offer a pacifier for non-nutritive sucking? Yes. Yeah, that could absolutely be some comfort. And then would we place them under a radiant warmer undressed? No. Right? That's one, it's not going to do, medically it's not going to help a lot. They're typically not having hypothermia issues, and they do better being swaddled. Right? So if I undress them, they don't have that close swaddling. Right? All right, so same thing. Do your 1 minute takeaway. Yeah.
Alcohol withdrawal in adults is like one of the worst, one of the most dangerous things to withdraw from.
Yeah.
Is it the same with babies?
So you would monitor them for the same thing, right? So we're always worried about risk of seizures. So if it looks like that scoring is going up, like on the NAS scoring, if it looks like they're going up, once it gets, at a threshold of a number, depending on the hospital protocol or facilities policy, then they would say, okay, we're going to start medication because we want to keep that risk down. We don't want them to seize. So, yeah.
They don't have like a CWAS score, like a alcohol.
Theirs is an NAS score, so neonatal abstinence score. And it looks at things like jitteriness and increased sucking and like excoriation on the bottom, high-pitched cry, that kind of stuff. So whatever the scoring is for the facility. And then typically once it gets at a certain level, it's okay, monitor again. They may change the time frequency. And then once it's above that level, then you initiate the protocol of whatever they would order, morphine or whatever. Yep. And then did I skip past this one? I might have skipped past this slide, actually. Just thinking of nursing interventions, we want to make sure we're monitoring growth and development. So again, looking for those physical things that they may have issues with, depending on when they were exposed to the alcohol, and then nutrition. Identifying any kind of coexisting mental conditions that go along that could affect their treatment, like ADHD. Treating any kind of, so medications, there's really no medication that's going to fix fetal alcohol syndrome. You can't fix it, it's permanent, but we can treat the associated condition. So, for example, if they had ADHD, we could medicate them for the ADHD. As they age, if they have issues with depression, we could medicate the depression. And then a stable and nurturing home environment, of course, is going to be associated with better outcomes, so we want to provide the support to the parent. And then realistic expectations on, this is the disability that they have. Their brain may not be able to function at the level of our brain, and so we have to meet them where they are. But we also want to promote their independence. And then recognizing the resources that are available for families, and always promoting a secure attachment with their caregivers, because that's going to give them a better outcome.
So this may seem like an obvious question. We call situations, and we call mandated reporters, we call for abuse, we call for neglect.
Right.
Out of the uterus. But in utero, you took drugs, you took pregnancy, you took the, that woman said, she took whatever. It comes out addicted to all kind of things.
So
That's
typically,
not a defense. Depends
on the state. In Louisiana, what happens is all the hospitals have case managers per facility or per floor even. Like the facility I come from, there's a case management that's assigned specifically to labor and delivery and ICU area. And so they get involved. A lot of times they'll make the report. But as far as removal from the home setting and all that, it's not very common. But DCFS would follow them closely, make sure that they have resources, make sure that they're keeping up with their care and appointments and all that kind of stuff. Because in the case of Natalie, that was her mom's wake-up call, right? So she woke up, she realized, I caused this, and so that got her enough to get in rehab, and now, they're a great family. So DCFS, their whole goal is, support keeping kids safe and keeping families together. Yeah, so, if at all possible. So if y'all wouldn't mind doing that little eval, just dropping it here. You don't have to put your name on it or anything. And y'all have a great day.
Have a good day. Thank you.
Thanks, you too. Hopefully it's cooler wherever you're heading. But if you're going to building 14, it's not. Okay. Oh, thank you. of their severity.
Of course.
Yeah, I've been
all you can do, you know?
Yeah,
Some
what
of them
else?
have premature death.
You're trying.
Oh yeah, you're right. Yeah.
Depending on like physical stress, they have issues there, like cardiac issues that could potentially occur. But I don't know of any hard fast number.
See, yeah. Did you buy more? Yeah.
The problem with me is this semester,